Next, we call upon Dr. Shail Vasavada to speak on visual outcomes following implantation of EDOF IOL in patients with macular degeneration.
Thank you very much. This study was funded in part by research grant support from Alcon Laboratories. So the purpose was to evaluate visual outcomes following implantation of a non-diffractive extended vision IOL in patients with pre-existing early dry macular degeneration. It was a prospective interventional case series performed at Raghudipai Hospital, Ahmedabad and Jaipur. Study population was patients above 40 years of age undergoing phacoemulsification for non-traumatic cataracts, and all eyes underwent in the bag IOL implantation of the Vivity IOL in this case. Patients with uncomplicated age-related cataracts and nuclear sclerosis ranging from grade 1 to 4 on the LOCS grading 3 system were included, with pre-existing stable early dry age-related macular degeneration, which was defined based on the AREDS2 study criteria. So early dry ARMD is defined as multiple small drusen's less than 67 microns or few intermediate drusen's 63 to 125 microns or pigmentary changes at the macula. So this definition includes clinical fundus photography as well as posterior segment OCT. Exclusion criteria were all patients with either wet ARMD, severe dry ARMD according to AREDS 3, large drusen's, or any other retinal or ocular pathology or comorbidities. The primary outcome was monoocular corrected distance visual acuity, that is CDVA logMAR, at 4 meters on the ETDRS chart. The secondary outcome measures were monoocular unaided distance visual acuity at 4 meters, monoocular uncorrected and distance corrected intermediate visual acuity, and similarly monoocular uncorrected and distance corrected near visual acuity at 40 centimeters. The age distribution, the average age was 68.5 with a standard deviation of 8.38 years. There was an equal distribution of males and females and almost equal distribution of right eye and left eye. And all eyes had an axial length, a normal axial length, no high myopes or no high hypermetropes were included. Average grade of nuclear sclerosis was 2. And 63% of the patients received a toric version of the Vivity IOL, and the preoperative corrected distance visual acuity was 0.36 logMAR. Coming to the results, the distance visual acuity of 40 eyes of the 40 patients, the uncorrected distance visual acuity was 0.12 plus or minus 0.07 logMAR. So 0.12 is equivalent to about 69 parts, and the corrected distance visual acuity was 0.1 plus or minus 0.1. So the mean corrected distance visual acuity in Snellens was equivalent to 6 by 7.5. The uncorrected near visual outcomes, which at 66 centimeters, which are our secondary outcomes, was 0.25 plus or minus 0.9. Corrected was 0.1. Similarly, the uncorrected near visual acuity was 0.23 plus or minus 0.1, and the corrected was 0.1. And the average near add required was 0.86 diopters for intermediate and 1.3 diopters plus or minus 0.18 for near was required. The most important part, comparing the contrast sensitivity with and without glare at different cycles per distance at 3, 6, 12 and 18 CPD. Without glare and with glare did not worsen. So one was not worse or one was not better than the other at all different cycle speeds. There is now early literature coming up showing encouraging outcomes of this particular IOL in eyes with subtle macular pathology. And therefore our study adds this part to the literature, which, because we have strictly followed the AREDS criteria both from the OCT as well as the clinical fundus picture point of view. So the conclusion is that the non-diffractive extended range of vision IOL, the Acris of Vivity, had very good distance visual acuity along with good intermediate and near visual acuity, but the most important part, without compromising contrast sensitivity. So the clinical implications can be that it can be selectively considered in eyes with stable dry ARMD. Visual potential in such eyes may always be suboptimal due to the disease per se. However, the IOL per se doesn't cause further deterioration of the visual acuity or the contrast sensitivity. So we can probably stretch the indications of using these technology IOLs to early ARMD cases as well. Thank you so much.
I just want to clarify what was the need for the torics. Was that the astigmatism was significant?
Yes,
How
astigmatism.
much was that?
So, sir, we calculate all eyes on the Barrett's toric calculator, and any eye which shows a calculation where the Barrett toric suggests an T2 or above, we consider it for toric calculation.
Was it a confounding factor, astigmatism being present and that one?
No, sir, because it was
Dr. Sale, did you have a financial disclosure?
Yes, sir. I did mention the first that it's a study. It's partly funded by Alcon.
Okay,
Yes.
that's why you have written
Yes,
ABT
yes,
IOL.
yes,
Now, how do you justify this enhanced monofocal having an edge over the usual monofocal, routine monofocal,
Yes, sir. So
on the context of macular degeneration?
yes, sir. So there are two aspects that we want to look at. One is the clinical outcomes suggest that the the extended depth of focus IOLs give a longer range of vision compared to the monofocals. The hesitation that we have is that particularly with the trifocals, multifocals, retinal conditions are a big no-no. So therefore, with extended depth of focus IOLs being relatively new, there is less literature on whether they can be used in ocular comorbidities, and therefore the aim was to see that are they safe. First of all, are they making the patients worse, which they are not. And we found that the near ad as well as the intermediate ad is comparable to what is reported in literature for normal healthy macular eyes.
Did you have a control group with an normal monofocal lens in those particular grades of macular degeneration?
No, sir. This was not.
Okay.
Thanks.
Did you give a relevance to pupillary size in these cases?
Yes.
Sir, it was not looked at in this study, but yes, there are certain studies which are looking at finding an appropriate pupil size, whether too small or too large may be appropriate for EDOF or not, but in this study we didn't look at this.
You have mentioned mesopic.
Yeah, so that is the mesopic pupil size. We measured the contrast sensitivity, but we didn't choose or exclude patients based on the size of their pupil.
Is there any difference in the magnitude of the myopia amongst this? What range they were in?
So, sir, the axial length was 23.17 plus or minus 1. 1.
So they were all matched.
all in the They were not. None of them were high myopes or high hypermetropes. Sir.
Okay.
Thank you, sir.
Thank you, sir.